Hello again, Jason Renault with the Alternative Mobile Services Association. I'm with Amy Barden today with Seattle Cares. Hello, Amy.
How you doing?
Chief Amy, right?
Yeah.
Well, welcome to AMSA. Chief Amy and Seattle Cares is an AMSA member of great standing, and we're glad to have her here to talk about House Bill 1811 in Washington State. So, Amy, first, tell us a little bit about you and about Seattle Cares.
Sure. So Seattle back in 2022 set up a third public safety department. Seattle 911 was taken out of Seattle Police Department. It was sort of dangling on its own without business supports, payroll, HR, the functions that you would need to be fully independent. And then there was also, by the prior council, there was $1.5 million put aside to launch an alternative response pilot. So I was recruited by this mayor. I had recently returned to Seattle from the Midwest, and I was recruited to stabilize this, set up the business structure, establish a new identity, right, for the third public safety department, and then figure out what to do with this pilot money. There was a few ideas proposed. They might respond to these call types. The job might look like this. And I just plugged myself into the academic community. I made friends with the folks at Georgetown, KICS, and NYU Policing Project, Chicago Health Lab, places like that to understand, is there a blueprint? Where is this going well? Where is it not? And very quickly learned that generally the programs that are really scaling and getting buy-in across political ideologies, they're programs that are designed to be integrated into first response. So you've got police and you've got fire, and then you have alternative response. The primary focus of my job is Seattle 911. So I'm unique in the country. When I started, there were about 75 alternative response pilots, three major public safety departments, right? So I often talk about Albuquerque and about Durham because that's a different design. And I really liked that design. I'm the only one with oversight of 911. And I sort of felt sorry for myself for a while because that's its own huge job. There's a lot of transformation and change right now needed in those first responders in that space. But then quickly I learned it's a significant advantage because I'm at the heart of the system, right? I uniquely can see the gaps, the overlaps, what's actually happening in first response, who wants to go to what calls, the co-occurrence of mental health, behavioral health, and crime, right? Or folks who are unhoused and some of these other issues. And so that continues to be my point of emphasis. I'm just looking at the call data. About 80% of these calls have nothing to do with law enforcement that I'm getting. It doesn't mean that law enforcement can't respond. We've compelled them to respond, but fundamentally
80%.
80%. Yeah, there was a study
80%.
of 1.2 million calls by Nick Jr. That was published in 2021, and about 6% of the calls for service had to do with felonies, right? Real criminal activity. And so usually publicly, I say about half the calls don't require fire or police. They just don't. In Seattle, like many other major cities, I am down about 400 officers. So on a Friday night, sometimes I have 58 patrol officers in all of Seattle. And that is incredibly stressful. We
Mm.
had a lot of escalating violent crime here between 2020 and 2023. It's just starting to trend down. So, but I've just been very pragmatic, saying I have to be able to get a cop to a priority one call expeditiously. Right now, on average, it's 11 minutes. And that means armed robbery, gun to the head, right? 11 minutes. And that's with staffing improvement. And so I'm saying, okay, police, they don't want to go to these calls anyway. And then there are a lot of calls that we have been diverting to the fire department. And fire doesn't want to go to those calls either. They're saying these are not high acuity calls. They don't reach our threshold of response. And so I'm left with, hundreds of thousands of calls a year that could be best responded to, should be responded to by a civilian responder. And that's what the CARE community crisis responders, that's what they're doing.
Wow. Just stunning. Just stunning. Well, let's dive in for a moment. But we have this bill. You've
Mhm.
testified on its behalf. It's had one hearing.
Mhm.
Going to have more.
Yeah.
Um, and this is House Bill 1811. There'll be a link in the newsletter so you can read the bill as we're talking. Tell us a little bit about how this bill came about.
Yeah, so I really need to start in 2023. So this is just as I'm arriving to this work. I'm new to public safety, and happily, there was already an effort, legislation that was being approved that was establishing a study of co-response in Washington state. How do we define co-response? What is a co-responder? Where does it exist? You know, it was popping up. We had a co-responder unit in police here since 2010, actually. We have Health One, Mobile Integrated Health.
Mm-hmm. Mm-hmm.
There are programs in Olympia, Tacoma, but it's not coordinated. And again, you've got a lot of variance in the field. And so this landscape analysis was commissioned. Dr. Jen Stuber at University of Washington conducted that. And then the Co-Responder Outreach Alliance was established. This needs to be a national model. What it effectively did was bring together everybody who is in the space of co-response. And I think of that as people who are not police or fire who are being dispatched to calls for service. You know, those are co-responders. Some are doing more care navigation, case management. Others, like my care responders, they're first responders. They're going out, they're triaging, they're on police channels. They have the same RMS system that police do. And ideally, we're expeditiously, again, getting somebody into whatever resource or onto whatever rehabilitative path would be appropriate. So we've got lots of different units. Right now, there's 50 around Washington state. Most are co-located with a police department or a fire department. But we come together, there's an annual conference. I think it'll be the third one this year. And there's a lobbyist and a very coordinated effort to say, okay, what do we need? How do we professionalize this workforce? How do we scale up and help the public to understand the nature of calls for service? Across the country, half the calls are behavioral health calls. In Seattle, my top two priority one calls is overdose and it's suicide. And so that is not a criminal justice question, is it? I mean, these are behavioral health calls and we should be sending the right first response. And so since 2023, last year, another big step forward after establishing this outreach alliance and sort of legitimizing the idea of a co-responder, last year, one of the critical steps forward was House Bill 2088, which extended liability protection and provision for all crisis responders in Washington state.
Mm-hmm.
And I testified for that one. I had learned that is imperative to the work, that I need my care responders to have the same protection and basically supports that police and fire have. And so that was successful. And then this year, there's actually three significant bills that we're working on. So 1811 that you mentioned, which provides peer support. 1809 also. These are strengthening behavioral health training and resources for all co-responders, extending mental health, behavioral health training, de-escalation for fire and EMS. You know, we just want everybody who's in this continuum of crisis response to have the same training, to be able to work together, to use shared vernacular and best practice in the state. So the way that when I was testifying for 1811, I said, anything you would provide for police or you would provide for fire, you need to provide for crisis responders. We need the same things. It's the nature of the work is very similar. So that's what that bill's about.
And the definition of a first responder, my understanding, is people who are heading toward the problem, not people running away from the problem. And that's that's mobile crisis as well as fire and police and ambulance. So but back up a moment and tell us about this special organization in Washington State. This is unique. I don't know of another organization like this. Tell us about CROA.
Yeah, so if you go, I think it's CROA, CROAWA, CROAWashington.com. And again, it's just this very well organized, volunteer driven membership where those of us who are working as co-responders in Washington State, we can join and be availed of updates. And we've got these sort of coffee breaks all the time. It's really just a community of practice where we're getting to know one another. We're looking for leading indicators of what works, but it's giving us a lot of credibility statewide. Generally, when I'm speaking publicly, I'm not talking about my unit. I'm talking about RACER, which is a mobile crisis response that serves 5 different jurisdictions up north. Brooke Bittner, right? Who's the
our friend Brooke.
President. Yeah. I talk about Tacoma Hope Team all the time with the fire department, Olympia Familiar Faces. What we're trying to do is socialize and normalize the idea that you need behavioral health first responders, that it's very important to invest. And then I'm generally also making the financial case that when you send the best first response, for me in Seattle, it's about 50 cents on the dollar when I send the care response unit versus police. And my folks are well paid. They're paid like first responders, but they don't cost the same. They don't have body cams, they don't have ballistic vests, we don't have the same overhead. And so I feel like there's a moral imperative to sending the right first response, but also you can make a great financial case. When you think about every time you see a, fire rig, right? I mean, think about just the expense of deploying these units, especially if what's really required is a skilled person having a conversation, connecting someone with resources
And solving the problem.
and solving the problem. Yeah.
So
So
you,
I encourage states to, again, with or without legislation, organize yourselves, get together, just have a listserv.
yeah, the CROA is unique in the nation. It's kind of what we're ambitious to do at AMSA, you're doing in Washington State. But tell us a little bit about your terminology is different than everyone else's too. You use the term co-responder. Most people use co-responder to mean a police officer
Yeah.
plus a mental health clinician of some sort. How do you define co-responder in Washington State?
Yeah, one of the things that I'm always trying to articulate is the difference between first response, primary response, meaning right from the 911 call, who gets dispatched. And we are unique right here in Seattle and care that I will dispatch the community responder, right? The unarmed responder without police or without fire. I
Hmm.
can do whatever configuration. We have lots of mobile crisis teams, and I consider that secondary response. So when you have fire screen or police screen, or they go out and say, this isn't us, can we get a mobile crisis unit? And then that crisis unit comes. And so I think about these professionals, though, in similar terms, and that they need the same skill set and they need the same amount of support. But it is important to articulate the difference between, do I need to get someone there in 10 minutes, right? Or something could
Hmm.
really go sideways versus, an hour. So what we mean by co-responder in Washington State is basically anybody accompanying first responders, whether you're arriving on the scene at the time or arriving just after. However that looks, we consider you a co-responder. You are part of that system of response. And so we have some units, again, who do care navigation, connect people to services. They look more like case managers. Health One in Seattle, they really are in the case management business. They will follow up. And my care responders, we're not doing that. We are rapidly triaging, we're de-escalating, and then we're hoping to hand off again to the right resource, whether it's shelter or detox, or somebody just needs food or they need to get back home. It's really triage. I'm not doing any case management so far. So, but we want it to be comprehensive so that individual jurisdictions can right size the response. What do they need? You have police departments sometimes who are broadly CIT trained,
Hmm.
right? You've got a really strong skill set when it comes to behavioral health issues. And then you have other departments that don't have any of that, really. It's just not a thing yet. So flexibility, I think, is important.
The continuum is quite wide at the
That's
moment.
right. Yeah.
So let's look at this HB 1811 and it does a lot of things. This is a big
Mhm.
complicated bill. It makes a lot of changes and has a lot of language and has a lot of definitions as well. Um, Tell us about the intention of this bill.
Yeah, one of the primary intentions of the bill is to provide peer support for all of these co-responders. So again, in year three, that was identified as just a significant gap, that there are unique challenges when you're in behavioral health first response. The psychology is different, right? And I think there, police and fire, we understand. We understand why it is stressful to be a cop, the types of trauma that you're exposed to, how that can accumulate, the adrenaline, all of those things. But through my lens, I think about dispatch the same way. um, Sometimes you're responding to a very complex set of circumstances where there really isn't a solution. You're doing your best to mitigate, but it's not like an acute emergency where there was a fire, I put it out, we're good, and I move on, right? Or sometimes police perceive, okay, I made an arrest, the person's booked, I did something. Very often, co-responders are going out and they're trying to make a difference in a very limited period of time with limited resources. I know in Washington State, we were ill-equipped to respond to fentanyl. And I know Oregon, same thing. I talked to the folks there too. we just didn't see it coming in some ways. I think law enforcement was aware of the proliferation and what the impacts were likely to be, but social services was far behind. I can tell you in Seattle, I think we were here debating the ideal definition of harm reduction while everyone died on the streets. So I've been very clear that's not appropriate, that we need a wide array of resources for people. But it's so painful. I've been out with different co-response teams when, we end the day in tears because you are in the space of profound suffering, of sorrow, of crisis, and sometimes of death, where we're trying to reverse an overdose and we're not successful. Or one of the more poignant moments last year, this was the Health 99 unit in Seattle fire. They intervened with a young man. They were able to revive him. And they were trying to get him into detox, trying to get him into treatment. He was ready. It was one of those good moments where somebody says, yes, I need help. I don't want to die. They cannot find a space for him. It's late into the evening. So they give him some Narcan and say, we will be here in the morning, that co-response team, and we will find you a place. There will be one, just nobody's open. And of course, they come back in the morning and he was deceased. We lost him in the night. That is unacceptable. And so that, again, uniquely co-responders are the ones informing the system redesign. What is actually happening? What are the gaps and what do we need? And that's my kind of unique position, is for whatever reason, I'm in front of the mic a lot right now, helping people to understand the actual threats to life. I often say we broke the homicide record in 2023. That was 73 people. That was horrible. It was 73 people. I lost 1,388 people to overdose, and would have reversed, I'm sure, tens of thousands of overdoses in the city. So we're just not acknowledging the suffering and what the intervention should be.
Hmm. And so
Sorry, I'm depressing myself. We're going to have to talk about something
I'm going to
positive.
stop and have a little crying session.
Yeah.
Yeah, I remember speaking to the medical director of the city of Philadelphia in 2022, and he said, you people on the West Coast don't know what we're having here. It's called fentanyl. And just
Yeah.
get ready.
Yeah.
So people knew,
Yeah. Well, it's the same thing with tranq, right? With xylazine.
right?
We
And he talked about
we tend to
xylazine
see
too.
we tend to see these trends, and yet we all always seem caught off guard, when it shows up in our communities. And I've been very, very concerned about rural communities because you see that they're proportionally, it's actually the same issues, the same challenges, whether it's rural or urban. And often urban environments are better resourced, right? We have methadone clinics, we have a different level of support.
So 1811 brings peer workers into the mix.
Mhm.
It also identifies, as my understanding, it identifies uh, crisis workers in general as first responders.
Mhm.
Could you
Yeah.
tell me what the value of a crisis worker being a first, what does that designation really get you?
Yeah, so some of it has to do just with benefits and with compensation, frontline employees. Um, it's legitimizing to people. I feel like, this is across our society. We have not valued social work, case managers, care navigators. I advocated for cahoots last year, in their sort of labor battle to be paid. And it was very distressing to me to know that I was starting very similar employees, right? Starting them at 3 times that hourly rate, which I still don't think is enough relative to the work. We want these to be professional career paths. This last cohort, so I've been scaling up the care crisis responder team. I have 24 now and 3 supervisors. And I just met with the last class as they're going through their academy and got to know each of them. And it was so interesting. Half of them moved for the job. They were watching it. I had somebody move from DC. That would not have happened historically, right? If I had a mobile crisis outreach job and somebody says, yeah, that is a job for me, and picks up their life and moves. But it's a great job. We're in an innovative space. It's treated with huge respect right now in the city. It was cute. I heard last week, as we sort of expanded to go citywide, a couple of my responders were walking in Capitol Hill, which again was a new precinct for us. And they said that there was a business where people like opened the window and yelled out, "Hey, care team, you're finally here." And I thought that was so awesome that they were already recognizable. And the city, these other neighborhoods have been waiting for them. And so that's what I want to see across the country. I want this legitimized. These are first responders. We need to pay them. And you should be able to have a good career path and have leadership opportunities and retire with a pension, after 30 years, the same as police and fire.
Well, it's amusing to me. I had quite a number of psychiatric crises myself on Capitol Hill, and I was looking for you, but I was 30 years early.
Yeah. Yeah. Yep. Not
So
much changes.
no, it's a great neighborhood.
Yeah.
Uh, so let's look at some of the meat of this bill, and can you point out to us where this language is? Because I think other people, I'm hoping other government relations staff is listening to this and thinking, oh, we could do this too.
Yeah. Yeah. I mean, I think in the first page, I know there's actually already an amended version of it, so I don't know which one you have in front of you. But if you just look in the very first section 1, where it describes what the goals of co-response are, and there's a nice little job description there. We talk about de-escalation, that we're diverting people from criminal justice and the ED departments, and that we're bringing medical and behavioral health care together to serve vulnerable populations. So I think that language alone is very, very useful. Again, we're a couple years out. So the original bills in 2023, sought to articulate that. Last year, you had a better articulation. And now we're extending to say in this bill, we need to establish a peer network of support, that this is different work than other types of peers, and that it needs to be professionalized. And then in 1809, again, we're expanding. There's something now called BH Corps. We've got basically a behavioral health co-responder training academy at the University of Washington. I encourage you to look that up. Anybody who's in the space, it is so cool. And the dream is, that there is a framework, that there is an academy. Most of us in first response, when it comes to human behavior, de-escalation, things like that, we should all be training together, right? We should have line of sight into the different disciplines and know each other and be using shared language. I think the relationships really matter, especially in different jurisdictions. I'm trying to think. So the peer language is really cool. If you look at section 2, that's focused on this peer support, which we feel like is just a gap right now when we think about how do we retain staff. And we're concerned, this is an emerging field, and I'm very concerned. We don't have longitudinal data yet about what are the mortality implications. I know a lot about law enforcement, and mortality is like 20 years less on average or something like that. If you're working in law enforcement, I know something about dispatch, same thing. What are the rates of suicidality or depression or substance abuse? And I don't know yet for co-responders, but I have reason to believe
Right.
that there's going to be adverse impact,
So some
psychological.
compensation for that
That's
impact.
yeah. Yeah,
Mhm.
that's right. And I think for all of us in the space, um, just to have acknowledgement, that yeah, it's hard. It's hard. And here is what you can do. Sometimes we need very professional clinical resources, but I think a lot of times it is the camaraderie and the friendship and the solidarity. I mean, my peers all around the country, we're usually commiserating about politics. That's what depresses me. I'm not in crisis response, but I do think it's really useful.
Well, this might answer sort of the lingering questions. Why do police officers and fire get to retire at
Yeah.
55?
Yeah. 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 I mean, it's the same as the military. I think it is assumed and understood that this is not probably tenable physically or mentally for 40 years for most people. For a lot of people, it's a 25 years, 30 years, or sometimes even less. And then you go into a civilian position or something adjacent. And I think there's good reason for that. I spend a lot of time in the police mental health space as well. And I've talked to different leaders around the country about that. And I was at it was a Council of State Legislators thing. I didn't know why they invited me. It was mostly, retired sheriffs and chiefs of police and some senators and people around law enforcement. But it turned out that it was folks from the Dakotas, from Montana, from Utah, places where mental health impacts were a little bit less normalized, and not as talked about. And I was so touched by the end of day 3, where we were all sharing basically how are we trying to provide mental health supports in different parts of the country. There was a man who's a senator now who reflected that when he retired as a police chief, he said I realized it was about 2 years into retirement, I started having normal dreams for the first time. And he said, I never thought about that as a mental health impact, and now I realize it is. And I was really touched by that because it reminded me we only know what we know, right? If this is my whole life and my whole career, I'm married to a very newly retired deputy chief of police.
You are.
And yeah,
Okay.
I mean, that was the fun rom-com of my first 2 years on the job. Yeah. Which is fascinating, right? Because my whole career has been spent in the space of hope and rehabilitation and interventions that work and heroics. I mean, really, in his whole career, 38 years, has been the worst of humanity, arrest and book. He did hard stuff. He was always over narcotics and intel and, that pretty brutal career. He loved it, but he never got to see my part. He didn't get to see drug court graduation, and he didn't get to
Yeah.
see when people actually are healed and rehabilitated, even in the carceral system, which again needs to be much better designed to do that. But he's starting to realize as he's hopping around my, communities of practice all the time that anybody can change. I say that all the time. People can change. And we've got to invest in the right first response, right? And then it needs to be diversion first, reserve coercion for when deflection or diversion didn't work. But even then, even if it's coercive, it needs to be so that somebody can change and can heal. We can redirect and address whatever is going on. And right now, I feel like we're still, intervening. We're arresting to punish. And that never worked. And it was never right. And we need to stop.
And it's vital that people at the front lines be able to see a little bit of the effect of their work later on, that when people do get
100%.
well and not just the
Yeah.
caskets.
Oh, totally. And I feel like when you think about police reforms, and cultural change, that would do more, right? If officers could be 50% involved with like prevention and reentry, or here in King County, we're bringing back the practice that we have a really cool drug diversion court here. I love it because it's pre-adjudication, right? So these are folks who have felony charges, but if you're successful, it's pre-adjudication. It's as though it didn't happen, which I think there's something really beautiful about that. But we had a practice long ago that the arresting officer was invited back to graduation, and that just kind of went by the wayside. So we're
I
bringing
remember
that
that.
back. And it's so touching. I try to go every month because people, share a little bit about their story and what they're looking forward to. And what always impacts me is seeing the generational healing that very often this person has kids that they haven't seen, or their mom is there, or their sisters. And I feel like if we would just intervene and help people actually heal and change. Again, in Seattle, it's very often substance use disorder. I mean, the corollary between SUD and crime, it is ubiquitous. I had no idea. And it's fascinating. I can't prove it in the data because I don't drug test everyone. But anyone on the front lines here understands that, especially with a drug like fentanyl, you can't survive, right? It seems like invariably crimes follow. And so I feel like, cool, let's address the substance use. No, nobody, I think we forgot that it is not a desirable state to be addicted to anything. It's not. It's not. That interferes with our relationships, whatever I'm talking about, gambling or shopping or alcohol or fentanyl, whatever we're talking about, we should still want to help people sort of transcend that dependency so that you have autonomy again. So, yeah.
These are heretical terms you're using. I mean, you're really turning the whole idea of policing and criminal justice on its head and
Mhm.
saying this is a public health problem
Yeah.
as much as it is a public safety problem.
Yeah, that is exactly right. I've said a number of times public safety and public health are the same, and we should be providing a very human-centered response to it. And in Washington state specifically, it's catastrophic, the design of the system, where I've got housing over here, but then there's all these different types of housing providers, and it's all uncoordinated. I've got behavioral health over here, I've got mental health here, I've got physical health over here, I've got criminal justice here, and it's an impossible system to navigate. And so that's the fun again of just tightening up first response, saying nope, if there's an emergency, right, if I need to get someone there quickly, that is a 911 call, that you should call 911, and the 911 dispatcher should have the discretion but also the availability of resources to just send the right configuration. In a perfect world, a couple of years from now, I hope that I can send care responders, and if I know it was somebody who's unhoused, I just have a peer with lived experience, a specialist right there on scene meeting them, right? Why can't we do it that way? Just send the person what we think would be the most useful.
Let's wrap by telling us what you think the future of this bill is. Where does it go next?
Yeah, I think a couple of our bills might get sort of collapsed into one bill. I think that this one is going to pass the House. If you look at 1816, that's a bill that gives more latitude for jurisdictions. Basically, once I've bargained the body of work, right, that alternative response can go to, there's latitude then for just the mayor or the executive to scale however they see fit.
Hmm.
And that's kind of important. It's a little bit King County specific, but that's really important to just be given the same latitude that police and fire are given to run the business and not have to, every time I add headcount, go back and bargain. The second part of 1816 is public disclosure exemption. This is imperative. Right now, we're not really capturing notes about the people we encounter because we've got public disclosure, and these are
Hmm.
vulnerable persons. And so, again, we're doing enough for research to say, this is what we encountered. These were the services connected to, but I want to be able to operate like police and fire, where I can capture data, especially about high utilizers. What was most useful with this person? If is there a diagnosis that's stated? That 1816 is, I think, more likely to pass the House, move on to the Senate, because it doesn't have a fiscal note. So Washington State, we've got budget shortfalls at every level of government. I think 1811 is going to be successful, although the peer support part might not be paid for, right? There was a financial implication there that there would be investment. So I just, budget.
But this would make Washington State the first state that acknowledged that mobile crisis team workers are first responders.
Yeah. Yes, to my knowledge. Yeah.
That is, I think we've done some searching. We've found some cities that have this
Yeah.
the case, and some other states that have put this forward, but it failed pretty quickly. But this sounds like it has legs. It has CROA. It has
Yeah.
you. It has good bill sponsors.
Yeah. Yeah, I think we have 20 on 1811. I've got 14 on 1816 as bipartisan. 1809, again, the one that's more focused on professional development. I think there were 16, 18 sponsors. So it's really good that, again, we're just normalizing this conversation, that it's becoming accepted that we need this. And I always say this is not political, it has nothing to do with politics. Look at the calls for service. Who do you need to send? And then design for that.
Well, thanks for talking to me, Amy.
I always enjoy it.
Take care.
Thanks.